Before we dive in, can you answer this clinical question? We will discuss the correct choice at the end of this video. Polycystic ovarian syndrome is an acquired endocrine metabolic disorder driven primarily by insulin resistance. This leads to excess ovarian androgens and ovulatory dysfunction. It's not just a gynecological condition, it affects the whole metabolic system. It impacts around 7% of reproductive-age women. Risk increases with family history and obesity. Let's step into its pathophysiology. Number 1. Insulin resistance. Insulin levels rise. Insulin acts like an LH booster on ovarian theca cells, which increases androgen production. It also reduces sex hormone-binding globulin from the liver, significantly increasing free testosterone. Number 2. Hyperandrogenism. This excess results in clinical features like acne, hirsutism, and sometimes male pattern hair loss. Number 3. Ovulation failure. High androgens and low FSH prevent follicle maturation. Follicles start growing but never complete development. No ovulation means no corpus luteum and thus low progesterone. Estrogen becomes unopposed. This leads to irregular bleeding and increases the long-term risk of endometrial hyperplasia and cancer. Remember, those cysts are not real cysts. Number 4. Metabolic effects. The underlying insulin resistance predisposes patients to obesity, dyslipidemia, prediabetes, type 2 diabetes, and fatty liver disease. Now the clinical features. Menstrual features include oligomenorrhea or amenorrhea, hyperandrogenism cause, hirsutism, and acne. Metabolic features as central obesity and acanthosis nigricans, reproductively, infertility. Pcos is the most common cause of anovulatory infertility. Diagnosis is based on Rotterdam criteria. Diagnosis requires 2 out of 3 of these criteria, 1 oligo or anovulation. 2. Clinical or biochemical hyperandrogenism. 3. Polycystic ovarian morphology on ultrasound. Always rule out thyroid disease, hyperprolactinemia, Cushing syndrome, late-onset congenital adrenal hyperplasia, and androgen-secreting tumors. Look for an LH-FSH ratio, often greater than 2 to 1 or 3 to 1, and elevated free testosterone. An oral glucose tolerance test is essential due to the metabolic risk. Ultrasound may show the classic string of pearls appearance, but imaging is not always required for diagnosis. Here's the treatment part for women not trying to conceive. Combined oral contraceptive pills are the first-line treatment. Metformin improves insulin resistance and cycle regulation. Spironolactone treats hirsutism, but only with contraception. Now, the treatment part for women trying to conceive. Letrozole is the first-line drug for ovulation induction. Clomiphene is an alternative. IVF is reserved for refractory cases. Most effective intervention overall is weight loss. Even a 5 to 10% reduction in body weight can restore ovulation and improve metabolic health. Complications include infertility, endometrial hyperplasia and cancer due to unopposed estrogen, type 2, diabetes and cardiovascular disease. Now let's go back to our clinical question. If you chose option B, that's correct. PCOS equals insulin resistance leading to androgen excess, which causes ovulatory failure. Understand this mechanism, and PCOS will never feel confusing again. This is the Y Medic, simplifying gynecology. Subscribe for more high-yield topics.